with us. So thank you so much for being here. I mean, I want to also thank all our resident discussants and also our presenter, Samantha King, for being on here too to participate today. We're really excited to hear this case. And so what I'll do is I'm Cory. I didn't officially introduce myself, but I'm the chief resident over at the University Hospital. And then I will let everybody else just kind of introduce themselves and what year they are in their residency.
Hi, everybody, and welcome. My name is Sam. I'm a third-year resident and went to medical school at the University of Kansas. Couples matched here with my husband, who's a physical medicine and rehab resident.
Hey, everyone. I'm Alex LaFever, coming from Eastern Virginia Medical School. I'm a first-year resident.
Hey guys, I'm Chris. I'm one of the third-year residents here. I was at Tufts in Boston before moving out here.
And hey everybody, my name is Jason. I'm also a third-year resident here in the hospitalist training track. And I went to medical school at the UT Health San Antonio Long School of Medicine.
Perfect. Thank you guys so much for introducing yourselves. So let's go ahead and we'll get to the case. But first, I just wanted to extend a welcome to all of our applicants. Like I said before, we're really excited to have you all here. So thank you so much for being here. And this is just kind of a map of where all of y'all are coming from. So all over the country, great representation here today. So thank you again. And then I just wanted to kind of go over our usual teaching style. So we are, when we're not in the era of COVID, we're actually doing in-person teaching, sometimes having a fellow who's actually here in this picture right now, presenting a topic for the day. Otherwise, it's going to be one of us chiefs giving a talk. We also, because of COVID and kind of making the hybrid of it, we've actually been doing these virtual conferences that have been going really well that you guys are going to be partaking in today. And then in addition to that, we actually have a YouTube channel which we actually record all of our virtual conferences. So please, if anybody is interested in learning a little bit more, please look us up on the YouTube channel at the CU Internal Medicine. So without further ado, I'm going to turn the board over to Dr. Gergen and then let Dr. King go ahead and say what this patient's chief complaint is and HPI, and then we'll go through the case with the discussants.
All right, thanks, Cory. So this is a 66-year-old gentleman coming into the emergency department with shortness of breath. He's been feeling unwell for about the past 4 days or so. He lives in Colorado, but was actually in Canada visiting some family. They were kind of hiking, camping out in the woods. He started to have a cough. It was dry at first. Now he's coughing up some white sputum. He's had some subjective fevers and chills. He didn't have a thermometer with him, so he hasn't actually taken his temperature. He also has a little bit of a sore throat. He got on the plane to come back today and actually felt so short of breath and unwell on the plane that he came straight from the airport to the hospital.
Great. That's fantastic. For all of the discussants, does anybody have any kind of clarifying questions or anything they wanted to elaborate on review of systems or the history?
I have to say it seems a little unoriginal that we chose a COVID case right now.
This was last September, pre-COVID era.
Or he's patient zero, one of the two.
True.
Is he, sorry, and you might have said this, is he from Colorado or he was stopping in DIA on his way here?
Yeah, he does. He's from Colorado. He lives up in the mountains. He was just on his way home from a trip to Canada.
And where in Canada?
He was in British Columbia.
Chris, why just kind of elaborate? I wanted to see what's kind of your reasoning for kind of figuring out where in Canada he is.
So I think of lots of different causes of shortness of breath with someone with white sputum, and I'm thinking about infectious causes.
Yeah.
To be honest with you, there's various endemic infections based on where you are in various parts of the country. Yeah. The reason why I always remember it, I guess, is because like I'm from the East Coast and we see like no tick-borne illnesses out in Colorado. But there's a heck of a lot of them on the East Coast that we kind of forget about when people move around. And so it just kind of gives me thoughts about where we're thinking and what things are more natural to those areas.
Yeah, really good. And I mean, just going with his history too, thinking about endemic infections, somebody who's been in the woods, hiking, camping, that's probably like, this is kind of the guy who is at risk for getting kind of one of these atypical infections. Alex, John, or Jason, sorry. Alex, Jason, anything you guys want a clarification on?
I guess it looks like we're going to get to this in a bit, but past medical history, anything abnormal for him, any immunosuppression, any other long-term illnesses?
Yeah, Sam, I guess any like does he have any reason to be immunosuppressed at all?
He is not immunosuppressed. His only medical history is he has a history of aortic stenosis from a bicuspid valve. So 20 years ago, he had a surgical aortic valve replacement. That was complicated by stenosis in the past couple of years of his prosthetic valve. So he had a valve-in-valve TAVR 4 months ago, meaning they transcutaneously put a new valve inside of his old bioprosthetic valve. That was uncomplicated, and he had been feeling fine until this illness 4 days ago. He takes aspirin 81 milligrams a day and simvastatin 10 and a multivitamin. And his only surgeries are those valve repairs, and then he had a tonsillectomy in childhood.
So I just wanted to comment quickly about like my general approach to this, given the information that I know. So when someone is presenting with dyspnea, I'm just thinking broadly of the big buckets of disease that could cause someone to become dyspneic. I think all of us, especially here in Colorado, know that lung disease can cause dyspnea. So definitely thinking about things that can be going on or wrong with the lungs. But another big bucket of disease is obviously cardiac disease, and we're starting to get some clues that this guy has a significant cardiac history. So that's another big common bucket that causes dyspnea. And then the other two big categories that I'm thinking of right now, systems-wise, there are metabolic processes that can cause someone to feel short of breath. And then finally, sometimes there can be something going on in the mediastinum. So not necessarily the heart, not necessarily the lungs, but something that's pushing on those structures and making someone feel short of breath as well. So that's kind of the categories I'm thinking of. Obviously, the fact that he's coughing and having a sore throat kind of points to the respiratory tract. The cardiac system is obviously coming into play here. We haven't really got labs yet or imaging yet to think about those other categories. I think the one other clarifying question I would have just in the HPI, whenever I find out that someone is traveling somewhere, in addition to knowing what region they're coming from and what's endemic to that region as far as infection, what were they actually doing? So were they staying in a city and at a hotel and eating at restaurants? Were they out and about camping? Were they swimming in lakes? Were they drinking out of ponds? Were they having some exposure to wild animals? So what was this guy actually doing when he was in Canada?
Yeah, great. So he was visiting family. They were staying with his sister-in-law, and then also they went on a camping trip. They went backpacking. So they were in the woods. They were hiking for a few days. Says he boiled all of his water before he drank it.
No, that's great, and that's actually incredibly great kind of framework that you kind of parsed out right there. And I think kind of what Dr. Albert was kind of alluding to as well, kind of with the metabolic bad blood, all the other things just to add on. Anemia, hyperthyroidism, which I think you were kind of alluding to, but he was just kind of getting a little more specific with that. But that's fantastic. And so just kind of like taking a step back, and you're interviewing this patient, and just you're seeing this patient, you've got your illness script of what you think is going on from him. Like if you had this patient that came in with these complaints, kind of what are you thinking is at the top of your list right now? So you can have any kind of clarifying questions or any other question, or really just so you know what kind of clarifying questions you need from them. Alex, what would you put at the top of your list?
Probably the top of my list would be infection, right? So some form of pulmonary infection causing dyspnea because of this cough. Number two, I would probably have either, it sounds pretty acute, so I would say cardiac would probably be my second. Like etiology to start investigating, and then Third, I'd probably put in any other primary lung pathology. So that's kind of where I'd start.
Yeah, no, that's great. And the reason I kind of want to go ahead and push y'all to kind of put out y'all's differential a little bit right now, because whenever in your HPI, if you don't have a differential when you're going through, you're not going to have your questions that you're going to ask to kind of clarify and take things out or add things in. And so I think that's perfect. Honestly, I think that's a great framework, kind of approaching this pretty broadly right now and thinking, is this pulmonary cardiac? And if it's with his current symptoms, thinking an infection is kind of the leading thing to go with. Chris, Jason, anything you want to add on, or I think it's pretty good, really, without having.
I don't think I mean, you could differentiate the types of pulmonary infections you're thinking about. We didn't really ask about other systemic things, right? Like rashes would be a really big thing that I would ask about. Hemoptysis, other respiratory symptoms other than just white sputum and shortness of breath. This guy has a known fake valve in his body, which is obviously predisposes him to having endocarditis, which could easily go to a bit aortic, so that really wouldn't get him there. But I mean, there's some other questions we could still add to this, but yeah, I think you would just be splitting hairs on what type of infection you're thinking about.
Yeah, perfect. I think August, he is having fevers and he is having fevers and sore throat. Sam, is he having night sweats?
He has not noticed any night sweats, no significant weight changes. And then to answer Chris's questions too, he has not had any hemoptysis. It's just white sputum. And it's really just the shortness of breath that is present at rest and also with exertion, and got acutely worse today.
And the two other things that I would throw in there. So I agree with Alex. Actually, the time frame of this is relatively acute, and that kind of narrows the differential a little bit. So in addition to infection, which obviously happens acutely, some kind of acute inflammatory process that's going on in the lungs that's not necessarily infectious. And then obviously we can't forget a pulmonary embolism as well. So those are kind of other pulmonary pathologies that can have a relatively acute on.
Perfect. And then one of the things I forgot to kind of clarify too, for anybody out there in the Zoom world, y'all are all welcome to participate. Any of the applicants or residents know that they can, but if applicants, if you have any questions and y'all want to unmute yourself or put any comments in the chat, you're more than welcome to, but please don't feel like you have to. I just want to make sure if anybody had if they wanted to participate, we'd love for you to, but it's not expected. So we'll just keep going with the case. So we got his past medical history of the aortic stenosis. Sam, what about his social and family and really, I guess, just big thing, yeah, social.
Yeah, so social history, he is a never smoker, no tobacco, marijuana, e-cigarettes, vapes, nothing inhaled. He drinks about 4 to 5 alcoholic beverages per week and no other substance use. He lives in Colorado, as we mentioned. He is retired. He was an accountant and he lives with his wife. His family history, really nothing. His mom has diabetes and that is it. And then he has no known allergies.
Perfect. And then I'm sure just for kind of going through pulmonary pathology, do we know what his occupation is?
He is a retired accountant.
Accountant. Okay, perfect.
And Sam, how many birds did you say that he has, and what are their names?
No birds.
Okay, and you have to ask that 3 times in the course of the hospitalization. It's like an AFB sputum or cytology. You have to do 3 questions before they'll finally tell you how many birds they have.
That's so true. Well, that's perfect, Sam. I think that's pretty good on the social history. Why don't we go ahead and let's get moving to vitals and physical exam, and we can come back to social history, anything if y'all want to, whenever we're going through this. So, Sam, what were his presenting vitals and physical?
Yeah, so a temperature was 38.3, heart rate 113, blood pressure 99/59, respiratory rate 24, and he was setting 90% on 5 liters. He has no oxygen requirement at baseline. And then on exam, in general, he was in mild respiratory distress and was tachypnic. HE and T exam was unremarkable. Mucous membranes were somewhat dry. He had no JVD. And then cardiovascularly, he was tachycardic but regular. He has no murmurs.
No, he did have a murmur. Sorry, I wrote that wrong. Apologize.
Oh, I'm sorry. He had a 2 out of 6 systolic murmur at his right upper sternal border. And no lower extremity edema. Poem-wise, yeah, mild respiratory distress tachypnic. He had some right-sided rales, more prominent in his right upper lung fields. Nothing on the left. No wheezes. Abdominal exam, soft, non-tender, normal active bowel sounds.
Perfect. And Sam, and if you don't know the answer, I know the answer to this, but one of Amanda was actually wondering, do we have like a previous echo for him? I guess kind of going back to his HPI on him, like what his last one was.
Yeah, his last one was after his TAVR just a few months ago. The new prosthetic valve was well seated with normal gradients. His EF is normal. Other than that prosthetic valve, it was unremarkable echo.
Perfect. So
any comments on his mitral valve in that?
His mitral valve was normal. All of his other valves besides his aortic were unremarkable.
Chris, I got to ask, why do you ask about his mitral valve?
You guys talked about right upper lobe rails. So I just think about MR. That's the reason why I asked.
Yeah, tell me, I want you, if you don't mind, I might press you out a little bit on that, because that's kind of an interesting point. Why do you think about MR when you hear about kind of right upper lobe pathology?
I believe Dr. John knows the pathophysiology a little bit better than I do. But essentially the thought of if you have an MR jet back up into your pulmonary vasculature, you're more likely to have it into the right upper lobe of your lungs. And so that's where we can see it in patients. It just kind of gets back to like what I was thinking about, is like, this guy's got a fake valve. He's got this infectious symptoms, what's going on with the other valves in his heart. I don't know. That's my train of thought.
And I couldn't have said it more beautifully myself, Dr. Caruso. By the way, we don't refer to each other as doctor. We're just being silly right now. We're on a first name basis here. But no, I think like the classic, chest X-ray, they'll show up on USMLE for acute decompensated or acute critical mitral regurgitation will be a right upper lobe infiltrate on chest X-ray. Although my understanding is you can just have like right greater than left pulmonary edema. It's not always that beautiful, but exactly what Chris was saying.
Good. Really, that's great, great teaching points. I appreciate you all chiming in about that. So, so why don't we just keep going, and we're going to go to the labs and imaging now. So you guys are guaranteed getting a CBC and BMP, but I was going to give each one of y'all one chance to get one lab apiece. Alex, I will give you first crack at picking the labs that you would want for this patient. So, but you're going to BMP. That's given.
Are we doing imaging as well, or just labs at the moment?
Just labs.
Okay. Let's see. CBC, BMP. I probably want a diff on the CBC. And then what else? Yeah, I mean, that's going to be my first thing. And I want to see his chest X-ray, but obviously that's not right now. So I will defer until imaging.
Perfect. Dr. Caruso?
I'd like a blood gas on this guy.
Okay, good.
I get one lab. That's probably the one lab I would get.
Perfect.
Spoken like a future pulmonologist, an excellent one. I'll throw in the TSH. I'll get it so that we don't miss this thyroid storm.
All right, so good. So, Sam, do you want to go through what his labs were?
Sorry, I muted myself. CBC, his white count is 15. Cory, I don't have the diff in front of me. I don't know if you do.
It's neutrophil predominant.
Okay, thank you. And then his hemoglobin is 17. Platelets 187. On BMP, his sodium is 136. Potassium 3.8. Chloride 100. Bicarb 21. BUN 18, creatinine 1.1, baseline is about 0.7, and glucose 117. His LFTs were
Oh yeah, go ahead. My bad, Sam.
LFTs were unremarkable.
And then what was his ABG?
Yeah, his pH was 7.5, PaCO2 of 28, PaO2 of 107.
On 5 liters or on room air?
Yeah, on 5 liters.
And then I believe his TSH was normal.
Can I get one more thing?
Gosh, it's like buying a vowel on this one, Jason.
Yeah, I'm gonna ask. You know, you don't get what you want unless you ask for it. So I would like to request a lactate, please.
It is 2.0.
Perfect. Very, very helpful.
And then just so we, as one of kind of the things I know right now, I think everybody's fixating on looking for kind of zebras on this, but kind of thinking like logically, if you have a 66-year-old male that's coming in with shortness of breath, what's kind of one of the things, and there's obviously hypoxia, what's probably one thing you're for sure going to check on them as well? So somebody puts in a BMP, good. But what I guess like making sure they don't have any kind of cardiac etiology for their shortness of breath. Yeah. So probably get a trope on this guy too. So so Sam, what was his trope in BNP?
His BNP was 343 and his trope was 0.42, and actually the ED had already gotten to it. The second one was 0.40.
Cory, I think I was joking about ignoring Chris Caruso at your own peril, but you definitely ignore Dr. Albert at your own peril, since he is the former editor of the Blue Journal and a pulmonologist from Seattle. We've got a Pacific Northwest shortness of breath case here. So maybe, Rick, do you want to add a thought here?
Yeah, please.
Well, one of the tests that anybody who comes in with a pulmonary infiltrate that's not diagnosed, the cause is not diagnosed, needs a UA to consider all the pulmonary renal syndromes. The TSH becomes a lot less useful when we know that he's got a big AA difference. If he has such hyperthyroidism from thyroid storm that he's in congestive heart failure, maybe he could have hyperthyroidism causing the AA difference, but he's got major gas exchange problems. So this is parenchymal lung disease of some sort.
And Dr. Albert, you just picked that up just on his vital signs, just looking at his SpO2 and his on the 5 liters.
Yeah, if he's got a saturation of 90 on 5 liters, he's got an AADO2. In fact, the PO2 of 107 is not consistent with the saturation of 90% on the same 5 liters. There's a discontinuity there, but regardless, the blood gases aren't going to help a whole lot with telling you what the diagnosis is. It'll just tell you that he's got parenchymal lung disease and that he's appropriately hyperventilating.
Perfect. Thank you, Dr. Albert. So so just kind of taking a step back, we've got these labs right now. You're going to go, you see this patient, you've got your physical exam findings. What imaging would you want to get on this patient right now? And any other image stuff, if you had to pick one test?
No, I would probably start with a chest x-ray just because it's fast, but I think this gentleman is going to very quickly need advanced imaging of his chest. Whether we do a CT like a PE protocol, or whether it's just a regular old CT chest, because I think he's going to ultimately need advanced imaging, but we could probably start with a chest x-ray and that would be fine.
Okay.
Yeah. And I'd also add in looking at this guy with a AA gradient mismatch and tachycardia, all that stuff, could be concerning for a PE. I went ahead and calculated his well score and it was 1.5. So he's in the low risk category. I think that he has other things that are more pressing. So I would probably save him the contrast and just get a non-con CT if we were going to do that.
Yeah, and I think and both of y'all are kind of alluding to probably look at the chest x-ray first, see if there's anything revealing on that. And if there needs to be further imaging, we'll go there. But obviously look at the chest x-ray and go from there. So I'm going to pull up his imaging and his EKG that he got in the ED. And Chris, I'll let you go through the EKG, and then Alex, I'll let you look at the chest x-ray, okay?
Okay.
So... And Chris, you being an R3, I'm cool with you just giving me what your final read on this guy is.
Yeah, I gotta get the chat out of my way for a second. So things I noticed for this guy. Oh, that's better. Somehow you can put the chat at the bottom of the screen. Look at that. Essentially, he's tachycardic, which we all knew. He's got big P waves in 2 that I kind of want to point out that I think are useful to look at. And then he's got the stuff when we're thinking about his trope. He's got no obvious, like maybe he's got the slightest of depressions in V6, but all of his T waves are upright. So I'm not too excited about anything there. So this is sinus tachycardia with a prolonged PR and a large P wave in 2.
Yeah, perfect. I think the only other things I'd probably add onto there is that he does have the line the precordial leads touching one another, kind of reaffirming.
Yeah,
Yeah, so he's got some LVH, and then
he's left axis deviated. Does that kind of make sense?
Yeah, and then Dr. Chan also points out looks like he's got some RV strain on there too. Great. Okay, so Alex, I want you to take a look at this X-ray. I'll give you a little bit of time, and everybody else is more than welcome to take a look as well and tell me what y'all think.
Okay. So just running through it, we'll start with airway. His trachea looks midline. His carina looks normal. Bones, I don't see any obvious fractures. It looks like he has some medium sternotomy wires in. So he probably actually, I don't know if those are sternotomy wires or his prior valve. The placement, I guess sternotomy wires. Looking through his lung fields, it looks like he has some fluffy opacities in his right upper lobe, and also potentially some in his, I don't know if I'd call that hilar fullness on the right, or if that's an opacity kind of towards the middle. Left lung looks relatively clear. It has lung markings all the way out to the edge, so no concern for pneumothorax. And then his costophrenic angles look clean, maybe just a little bit blunted on the right. So there's a possible chance for an effusion there. Otherwise, heart size looks normal. And I don't see any other like really concerning things on it.
Okay, good. Thank you, Alex. Dr. John and Dr. Caruso, anything you want to add on this chest X-ray? So it sounds like pretty much right upper lobe infiltrate and maybe some right lower lobe perihilar fullness there as well.
Yeah, I just had a couple of quick comments. So this is actually helpful that we got the chest X-ray first, because could he have a clot in his lungs? Possibly, but it definitely wouldn't explain all the changes that are seen on this chest X-ray. A PE in isolation is quite unlikely to be going on here. And then the other thing, it's always a little hard to see on the screen. I always get nervous saying this in the presence of esteemed pulmonologists, but this chest X-ray actually looks a little over penetrated. We always talk about film quality. And the reason I point that out in this situation is because if you have a film that's like a little bit over penetrated, where I can see the spinous processes through the cardiac silhouette and I can see vertebral bodies below the diaphragm, And then we see these infiltrates. They actually may be kind of like not looking as bad as they might be. And I think there's a possibility that a CT scan may look, this chest X-ray looks, kind of fluffy, but we may do a chest CT and it might look pretty gnarly. So just pointing that out.
Good. Thanks, Jason. Since we do have a couple pulmonologists on this call, Dr. Connors, Dr. Albert, anything y'all would add on this chest X-ray when you take a look at it?
I'll go first because he's more esteemed than I am. But I will say, yeah, I agree. Jason, you're correct in what you're saying, which is if you blast the film with too many X-rays, you'll get bones down below the abdominal contents visible, and everything else gets less impressive. So I agree. I think the CT is going to probably look worse than we expect. The only thing I'll add to this, a couple things is I will go ahead and just add to what Alex said and say that there is true blunting, especially on that right side. It's fairly obvious. And what I like to say, and I know the residents heard me say this, is that the costophrenic angle were made of metal. It should be able to cut you. And if you see something there that you're not afraid of cutting you, then we can then debate about what is abnormal there. That diaphragm is also higher than you expect. And yes, the right hemidiaphragm should be higher than the left hemidiaphragm, but not by that much. And so then you start thinking, is that because there's something below it pushing up or something above it pulling? And now you've got both possibilities because you've got fluid below and you've got an infiltrate above. And then I'm curious to see what Rick has to say about this. The mediastinal stripe on the right is incredibly straight. And so it runs from where you would expect the SVC all the way down the IVC to be. One possibility is that anytime you've had a mediastinoscopy or a chest that's opened, the mediastinum remains wide for the rest of your life for most people. And so that may just be what it is. It's the straight line nature that has me most curious. So could that be vascular? Could that be some sort of collapse? I don't know, but as the radiologist will tell you, there are no straight lines in your body. But otherwise, I think you guys are on the right track, and that right upper lobe infiltrate is the thing we thought we might see.
So the only other thing I would add, two things. First is the film is lordotic. Look where the clavicles are relative to the apex of the lung. And that could account for the second thing that I would comment on. I think the upper lobe vasculature is increased in diameter. I think he's got redistribution of perfusion to his upper lobes, at least on the left. But that could be because we're looking at a lordotic film. Penetration to me is kind of okay. I wouldn't have called anything there. If anything, I would say maybe a little underpenetrated because I have trouble seeing the vertebral bodies through the heart. I can see them, but just barely. There is an effusion on the right, certainly. With respect to the mediastinum, I see what you're looking at. I wouldn't have called anything, and my first inclination is to attribute it to the mediastinal surgery that he's had. I don't think there's anything else there. And this is a three or four-fold remove from looking at the film itself, computer versus, whatever. But I wouldn't be surprised if there's a reticular infiltrate in the right lower lobe out by the pleura. I don't think there's anything in the right perihilar area. That's the world's most difficult area to call on a chest X-ray because the pulmonary arteries are going vertical and the pulmonary veins are going horizontal, and there's a lot of overlap and smush there. So unless you've got silhouetting of the heart border or a clear infiltrate or a diaphragm silhouetting, be real careful about calling things in that costal cardiac junction there.
Great, that was fantastic. This is it's great to have a pulmonologist on here to help us with his chest X-rays. So that was fantastic. And the final read on this was, to simplify, was that right pleural effusion that you guys commented on, and also that right upper lobe airspace disease. And so he did end up doing a CTPE as well. And I was just going to show you the soft tissue going through twice, and then I'll show you the lung views of it after that.
And while it's going through, I'm going to go ahead and agree with Jason here. I don't know that I would have contrasted this person with a creatinine that's 40% off a baseline and while we may find a clot, and I'll be happy to be wrong when we find one here, it's not explaining everything that's going on. And so I probably would have saved the glomeruli at this point.
I agree with that, although I'll bet it's all dilution, concentration, volume depletion, because his hematocrit was too high. And I don't think this guy is chronically hypoxic from what we've heard.
Yeah, no, I totally agree.
And so here's his lung view of the same CTP.
So while I waxed poetic there, was there a clot that I missed while I was talking?
No, there wasn't a clot.
All right, good.
You were right.
I don't have to be right. I just don't want to be wrong too publicly.
Yeah, exactly. I would honestly, I'll message you later about Dr. Compton. So the read on this, no PE, and they comment exactly what y'all had said. So he's got the right upper lobe and left lower lobe opacities and likely infectious in etiology. And then also comment on his right pleural effusion and comment maybe is a parapneumonic effusion. So you admit this guy, you've got this imaging, you got his lab. What do you want to do for him when you're admitting him? Are you comfortable with the workup? Do you want to start him on any therapies? What would you do right now?
This is actually a good pause point because my suspicion, based on the setting we're in right now, is this is not going to be community-acquired pneumonia that resolves with azithromycin and ceftriaxone. But I know that this is a 66-year-old guy with a significant valvular cardiac history and recent travel, who's basically coming in with evidence of new hypoxemia and dyspnea, and just kind of putting it all together in evidence of an acute inflammatory pulmonary process, which definitely includes some kind of bacterial infection. And then based on his vitals, we don't kind of know where he's at in his trajectory, but he has a new 5-liter oxygen requirement. He's tachycardic and he is hypotensive. So definitely concerning for evolving shock, unclear etiology, but definitely septic shock. So bringing this guy in, he is someone who I would definitely start on broad spectrum antibiotics. And mainly when I say broad spectrum, I mean, covering with IV antibiotics for community acquired pneumonia. And then, ask for forgiveness later when we discontinue them because it's something else.
Yeah.
Is this where I get my swan, or is it too early for that?
It's never too early for a swan, Chris. Yeah. So why don't we, Jason, I completely agree.
Never use a swan.
I'm just kidding, obviously. No, but I agree with you, Jason. A 66-year-old coming hypoxic. He's got right upper lobe, right lower lobe infiltrates. And he's coming in, he's febrile, he's got a white count. Yeah, I think that's totally reasonable. Or that's what I would do too, is I would treat this person as community acquired pneumonia. So why don't we?
I also think we need to have either like a formal one if possible, but some sort of like ultrasounding of his heart at some point, just to make sure that we don't have some critical valvulopathy, that we don't have some kind of like prosthetic valve dysfunction. I think that needs to happen sooner rather than later, given his
when his blood pressure keeps dropping, when he gets a central line, if someone could do a venous sat and a CVP, that would also be great.
Great. So he's not there yet. So why don't we talk about his hospital course? So Sam, what happened when this person was admitted? When he got admitted, what did the team do?
Yeah, great. So they did basically exactly what you all said. They treated him for sepsis. So he had blood cultures drawn. He got a 30 cc per kg fluid bolus. His blood pressure came up. His heart rate came down. He was started on ceftriaxone and azithromycin and admitted to the floor. He started to improve. His oxygen requirement was weaned down to 2 to 3 liters. But then on hospital day 3 is when I met this patient. We got a call that this patient is progressively more hypoxic, was on 2 liters this morning, and now he's on 15 liters non-rebreather, still desatting to the 80s. He's in respiratory distress, and his heart rate has gone from in the 80s to in the 150s. And then I think Cory has a new EKG and a new chest x-ray for us.
Yep. Thank you, Dr. King. So this is his new. So you get he gets hypoxic. You get EKG, and has a new tachycardia. And so this is his EKG that you see.
Hey, Sam, while everyone's looking at that, did he clinically look better during these 3 days? Is he someone who continued to look ill and got more ill, or were you guys thinking, okay, he's making the turn, and then he acutely got sick again?
It sounds more like the latter. I was not following this patient at this time, but he was getting better, weaning oxygen requirement, looking comfortable, and then had an acute decompensation on day 3.
Okay, great, thanks.
So, and I'll just so we can kind of keep going. Dr. John, do you? I'll let you tell me what your final read on this EKG is. And this guy's, yeah.
Yeah, so my knee-jerk reaction, this is always stressful to do computer. I'm seeing an irregular narrow complex tachycardia. That's like my knee-jerk reaction. And then there's obviously a differential for that, the most common being, rapid AFib. I'm trying to look for P waves if I can see them, which I'm not necessarily seeing. I don't know if any of my colleagues can help me out if they're seeing them.
I would
But
agree.
I don't know. It's concerning for
concerning
rapid AFib.
Yeah, so exactly. So he actually went into AFib with RVR, and that's exactly what this read is. And then this is the new chest X-ray they got.
I'd say that looks worse.
I'm appreciating some interval change.
Yeah, it looks like his entire right side is worse. And I don't know if it's just the film with the bottom left.
And whenever you guys get a new chest X-ray, it's always good to compare. And so this is what his admission chest X-ray looked like. And I think if anybody, also just to kind of add, Dr. Albert put some really great things to be thinking about with this patient, with some possible atypical exposures with kind of acute fever, brucellosis, and tularemia, and kind of if he's immunosuppressed, making sure to check for PCP on him.
Yeah, I wanted to comment that this guy, particularly because of his travel history, you need to ask some questions. Has he been around sheep, goats, parturient animals, cats, rodents? Does he have any skin lesions consistent with tularemia? When he was did he drink any unpasteurized milk or eat unpasteurized cheese with regard to brucellosis? There's a list of quote, atypical pneumonias. We're not supposed to talk about typical versus atypical pneumonia anymore, but it's really useful to have a list of unusual organisms so that you ask the right questions. You already talked about birds for psittacosis or chlamydia. Even TB is on the list here, although not very high. But those kind of questions certainly need to be asked while you're in the process of covering him for community-acquired pneumonia. You could even, given that history, now that he's getting worse, you might, without that history, add doxycycline to cover most of those. Would not be inappropriate to do that.
Yeah, I completely agree with you, Dr. Adams. Oh, go ahead. Sorry.
No, that's great. I was going to offer my agreement there, and I was going to say that the other thing to think about when you do get into these atypical categories there are diseases we think of as affecting the immune suppressed, although they do appear in the competent, nocardia being one of those that can show up with these sort of rapidly advancing infiltrates. And then probably the only other one that I can think of regionally, and I sort of teased Ed a second ago, he asked about blasto, and I said, well, not blasto, but Cryptococcus gattii is for odd and interesting reasons now endemic in the Pacific Northwest. And so that is on my Seattle differential. So for those of you, if you choose to go to Seattle for residency, don't forget Cryptococcus. Not that anyone should do that, but Ken Steinberg's a pretty good guy too.
That's awesome. That's great. I was going to say Cryptococcus. That's pretty awesome. So yeah, so they commented, they said the read on this X-ray, which you guys were talking about, predominantly this right side is looking worse, and right side is looking worse, and maybe there's a little bit of interstitial edema. So Sam, you saw this chest X-ray. You had the EKG. What did you do when you got called about him?
Yeah, so this guy was in rapid AFib when we saw him. He actually converted back to sinus rhythm just with one vagal maneuver. He blew into a syringe and was back in sinus. But his oxygen requirement continued to worsen. He was put on heated high flow, and in a matter of about 30 minutes was on 90% and 60 liters. So he was transferred to the ICU and intubated with the thought that this was either ARDS from community-acquired pneumonia or it was cardiogenic pulmonary edema. And so now he does get an echo. His aortic valve continues to look good. The prosthetic valve's well seated. The gradients are normal. He does have a new mild regurgitant mitral jet that is new as compared to prior. And then he is rapidly prone for refractory hypoxemia. Do you want me to get in?
Perfect.
Do you want to pause there or do you want me to get into the rest of
So I have a question. We proned him for rapidly progressive hypoxemia that could be cardiogenic in nature and therefore not defined as ARDS.
Correct. It was unclear still at this point, yeah, which it was, and so he was treated as if this were ARDS prone.
Yeah, and
Sam, a great part of these. Oh, sorry, I'm so sorry.
No. I think I was gonna kind of piggyback off of what Sam was going with and why he got prone. What do you remember? What his P to F was when after he got intubated and when he was in the unit, and why you?
It was 80 on 100% FiO2 initially after being intubated.
So what I was going to say is, one of the great things about cold cases is you get to talk about things you don't know. And one thing that I don't know is we have a new mild regurgitant mitral jet, which is obviously, pretty underwhelming and not completely satisfying, but where acute severe mitral regurgitations in the differential for a right upper lobe infiltrate. I wonder in the setting of rapid AFib, if that mitral regurgitation becomes transiently more severe, and then in a normal rhythm, it's less severe. I do not know that, but it's just something I'm thinking about.
Or you put in the cart before the horse and the MR is causing the AFib from his dilated left atrium.
Yeah, so I really appreciate that you guys are kind of taking, y'all are kind of doing what you're supposed to do in medicine. When you have a patient that you're doing all the right things and things aren't working out, and you kind of have your knee-jerk reaction on how to treat what you think is going on and it's not working, you got to take a step back and kind of reevaluate the situation and kind of look in depth into what's going on. So you've got this echo, you've got this x-ray, this patient who's now being treated for ARDS. What would you want to do right now? We're going to continue antibiotics, consult anybody else, do any other interventions?
Did anyone ever try and tap that pleural effusion? It was tiny. I know it was on the CT, and CTs overestimate pleural effusions, but I didn't know, did it ever get bigger, and did anybody ever think to see if there was enough to tap?
Yeah, and so I guess I can get into a little bit. Once he was intubated, he became persistently febrile, despite broadening antibiotics to vanc, cefepime, flagyl, and azithromycin. That right-sided pleural effusion was tapped and drained, and it was transjudated.
And I'm also assuming we're operating under the assumption that his infectious workup with his blood cultures were negative at this point, as was his effusion cultures.
Yeah, so first set of blood cultures actually came back 1 out of 2 coag negative staph. Repeat blood cultures were no growth to date. Nothing grew out of that pleural fluid. There was nothing on gram stain. pH and glucose were normal.
Did he get bronched?
He did not get bronched because of how hypoxic he was, but they sent a trach aspirate that didn't grow anything.
Did you send it for fungal stuff?
Yes. He also, while persistently febrile, on day 5, I believe, developed a new apical holosystolic murmur. He did get a workup very similar to what Dr. Albert mentioned for serologies for fungal and more atypical organisms, thinking that maybe he had a subacute bacterial endocarditis. All of that workup was negative. He did then get a transesophageal echo, which showed a flail anterior leaflet of his mitral valve. And a linear mobile density on that flail leaflet, which looked like a chordae, but could be a vegetation.
So Sam, just for the last kind of couple minutes before we kind of get a little bit of some teaching points, so what ended up happening with this gentleman?
Yeah, so he did ultimately end up going for a right heart cath because the discussion was, in retrospect, how much of this was acute mitral regurg and cardiogenic pulmonary edema versus community-acquired pneumonia, then leading to acute respiratory distress syndrome. And there was discussion because of his degree of hypoxemia and clinical instability of whether or not he should get a mitral clip, so an endovascular repair of his mitral valve. But infective endocarditis is an absolute contraindication to that because you're putting a nidus of infection onto an infected valve. And with the persistent fevers and this possible vegetation, couldn't rule that out. So he goes, he gets a right heart cath. His pulmonary capillary wedge pressure is 27. And then his V wave, for what it's worth, I won't get into the details, but is 40, which is a measure of regurgitant mitral jet, which is very high. So he has hemodynamically significant mitral regurgitation. Ultimately,
Sam, sorry.
Go ahead.
Oh, I was just going to ask, like, did they comment on the valve structure? Like, is this more like he got a lot of fluids because he was septic and then his LV dilated, and so it's more like functional MR, or is it that he has a flailed leaflet and it's, I don't know, just curious.
Yeah, he has a flail anterior leaflet. Good question.
I think Mikhail's question is like, do we think he had the flail leaflet the whole time, or because that was the part I was stuck with, is like when he got 2 liters of fluid or whatever, he got his 30 cc's per kg bolus and got better, for it to be cardiogenic shock from MR seemed odd to me that he got better with fluid and antibiotics. Whereas I think if I gave him fluid and he got worse, that would have been almost diagnostic in ways to me.
Yeah, I agree. I can't really explain why he got better with fluid. And I've spent a lot of time thinking about whether or not this was entirely acute MR or whether there was a component of infectious pneumonia and maybe an overlap with ARDS. And ultimately, I think in retrospect, a lot of this could have been acute mitral regurg. It explains his chest X-ray findings in the beginning. It explains his, development of pulmonary edema, his development of AFib, and exactly like Jason said, I think with the rapid rate had worsened regurgitant flow, and especially the transudative fluid makes me think it was acute MR also. But as also Jason said, a guy coming in with fever, productive cough, and a focal infiltrate on chest X-ray, you're going to treat this person for infectious pneumonia. And I think you're going to ventilate them as if they have ARDS. I think you have to use lung protective ventilation in this person, but maybe what could have changed is more aggressive diuresis up front.
Yeah.
Ultimately, what's that?
And some afterload reduction too, like having had a crystal ball.
Yeah. So after that swan, he gets started on an icardipine drip and a Lasix drip, and does have improvement in his oxygenation. And he ultimately underwent a repeat sternotomy for mitral valve repair in lieu of a MitraClip because we couldn't rule out infectious endocarditis due to persistent fevers. He was extubated on post-op day 1, and they sent his ruptured chordae to pathology to look for infection, and pathology was negative. Looks like acute idiopathic chordae tendineae rupture. And I think a couple of interesting learning points for me from this case were that 50% of patients with acute MR do not present with a murmur. This patient didn't develop an apical murmur until hospital day 5. And so I think it's entirely possible that he had a flail leaflet when he came in. And it's actually relatively common to have that and not have a murmur. And then also TTE, so transthoracic echo, underestimates the severity of valvular dysfunction, particularly mitral valve. And I have sensitivities written down, but the sensitivity for transthoracic echo for mitral regurg is 44%, whereas transesophageal echo is 74%.
What a case.
Yeah, and so there was a, and this is just a quick mnemonic I was gonna, that the illustrious Dr. Connors had actually told a lot of us in the program about whenever we get to work with him.
Is it my mnemonic for subacute flail mitral MR?
Exactly.
Great.
You know what? Once it hits you once, you're never going to forget it again. But this is a great mnemonic that Dr. Connors has actually told us multiple times. But when you have an upper lobe predominant pulmonary disease, to think of the mnemonic Aztecs, which is ABPA, sarcoidosis, TB, eosinophilic diseases, as well as edema, which is from the acute MR, and then cystic fibrosis, silicosis. So if you, Dr. Gergen, who is one of the other fellow chiefs, actually devised this slide, and he did a great job kind of pointing out kind of the reason for that right upper lobe predominant infiltrate with the mitral valve is when it flails, it just kind of goes directly into that right upper lobe. So that is the case. And I just wanted to thank all of our discussants. That was a fantastic case. I told Dr. King to give you all as hard of a case as possible. So well done. Chris
And he
called
crushed it up front. I know.
Chris called it like 10 minutes into the case. And I was like, yeah.
So
Yeah,
I'll say I had no idea. I specifically emailed Cory last night and said, when I get too confused, I'm just going to ask for my swan. And Dr. Albert's absolutely right when he says that we should never be using swans in people with septic shock because the data says that, right? And that's why, and I was flippant about CVPs and venous sats. But the point is, like, we have really simple tools at our hands when we get confused about what's going on to try and help us differentiate things that are not a swan. That can be super, super helpful. Like the fevers didn't make sense to me, but like a new murmur in someone that's dumping all of this stuff into their lungs, like, I feel like you gotta start looking at their heart more.
I don't, I think we have to be dealing with fleas and lice here. The flailed leaflet's not going to give him a fever, persistent fever. I would think he had an infectious process in his lung, and I'm really surprised that pathology didn't see endocarditis as the cause of the flail leaflet. But I can't attribute the whole thing to mitral regurg. That just doesn't fit.
Yeah, and Dr. Albert, as a kind of a side note too, with the persistent fevers, before they actually found out he had a flailed leaflet, they actually did ultrasound all of his extremities and did find like I think it was, he had a left IJ thrombus, and I think he had like a left upper extremity thrombus too. Now, I don't think that, I agree with you. That's still, I think, a little bit of a stretch to, yeah, I agree. Snails, I think you're completely right. I think trying
Hickham's
to,
dictum.
huh?
Hickham's dictum.
Yeah, I know.
He can have as many diseases as he darn well pleases.
I know, and I think trying to Hookham's razor with it is probably gonna, we might be extrapolating a lot. But I think that the primary team did a fantastic job of treating this guy's underlying and treating this as infectious etiology, and then once things were making sense, taking a step back and reevaluating what was going on and figuring out probably what was the reason for his pulmonary edema. So, all right, so I know we're right over time. So thank you everybody for participating. Thank you applicants for being here. And I will turn it over to Dr. Connors now to go over the next steps. So thank you all.
That's great.